Hello, good morning and good evening to other doctors and participants from other parts of the world. Welcome to this 27th TCTAP 2002 live demonstration, but actually it's not live because of ongoing pandemic. This session is on complex PCI, and my co-moderator today is Dr. Lawrence Garcia from Boston. For housekeeping, I think each presenter has about 6 minutes and 4 minutes discussion after that. And please keep to the time limit. Without further ado, I would like to introduce the first presenter, Dr. Romeo Yumul from National Institute, Heart Institute from Malaysia. Dr. Yumul.
I'm here to present our case from National Heart Institute, Malaysia, entitled Management and Retrieval of Undeflated Non-Compliant Coronary Balloon During PCI. I have nothing to disclose. So the case is a 56-year-old woman with a known hypertension and diabetes and dyslipidemia. She had intermittent episodes of angina on exertion and diagnosed with chronic coronary syndrome. Workups prior to the angiogram showed an ECGO with a non-specific STT wave changes and a 2D echo of preserved LV systolic function, but with the note of segmental wall motion abnormality suggestive of multivessel CAD. However, despite starting her on optimal medications, there was persistence of the angina. Hence, she underwent coronary angiogram. Here is the diagnostic angiogram of the patient. So in the video on your left, shows a moderate to severe stenosis in the mid-left anterior descending artery and at the distal segment. But for the purposes of this discussion, we're more concerned of the osteoproximal stenosis of the right coronary artery. So seen here. So there was also note of a totally occluded posterolateral branch of the RCA. So the plan was to do the angioplasty first of the RCA. So here is another angiographic cine angiogram of the RCA showing the 80% proximal stenosis extending into the ostium of the RCA. Sorry. So on the image in the middle, we started off with a 4.0 by 15 millimeter scoring balloon and then inflated again in the aorto-ostial segment. So after pre-dilatation, we deployed the stent. It's a 4.0 by 18 Zotarolimus eluting stent at 20 atmospheres. So the last video shows the cine angiogram post-stent deployment with a telemetry flow. So we then proceeded with the post-dilatation with an NC balloon using a 4.5 by 15, initially inflated at 18 atmospheres. However, after the first inflation, there was difficulty in removing the non-compliant balloon despite forceful pullback. Hence, we did another inflation at the aorto-ostial segment at another 18 atmospheres. However, after that, we cannot deflate the NC balloon, and the patient is started having chest pains with noted new onset ST segment elevations and the ECG. So at this point, what to do? So all of the following did not work. We tried to force pullback into the aorta. We tried negative pressure in deflator. We used 50 cc of syringe to manually aspirate and then change to a pure saline and then reattach to a new indeflator. And we even used the stiff end of the coronary wire to perforate the balloon. But all of these were unsuccessful. So following the approach given by the Euro-PCR group, we tried the ultra-high pressure inflation to burst the balloon. But this technique or strategy comes with a risk of having a dissection or perforation. But since we have no other choice at this point, and the patient is already being unstable, the risk of dissection and perforation were thought of to be minimal because we already have the stent in place. So we went for it, and luckily, after ultra high pressure inflation, the balloon was deflated. However, another problem arise. We cannot remove the balloon because it's already deformed. So what we did was we inserted a femoral access and then used a 6 French snare. As you can see it here. On the right hand of your screen is the in vitro demonstration of the technique that we used to provide counter traction. So we can straighten up the deformed balloon and try to pull it back again in the catheter. So after that, we were able to remove the whole system via the radial sheath, including the wire and the balloon on inside the catheter. So as up to the radial axis. So there was no difficulty at this point. Final angiogram showed fully expanded stent with TME3 flow. So what happened? So one possibility is the occurrence of an invisible kink in the metallic hypotube, which allows for positive pressure inflation but not negative pressure deflation. So this was caused by maybe our forceful pullback and then causing this one. So in conclusion, undeflatable balloon is a rare and unpredictable complication during PCI, which may lead to serious consequences. Excessive stretching during pullback might have damaged the balloon and altered its mechanism. Deflating the balloon is one thing, but retrieving it is another. The use of snare in this case was invaluable, which prevented other possible complications. Thank you for your attention.
Thank you. That was a great presentation. This case is now open for discussion. We have a series of great panelists, Dr. Sao, Dr. Chow, forgive me, Tiernan, I will destroy your last name, Dr. Angiography, and Dr. Buzayev. Any questions for the presentation?
So, Dr. Yumo, thanks for your case. It's very challenging, but I have a question for you. Before you use the ultra high pressure to burst the balloon, have you thought about to use a guide extension catheter, such as Guyana or the Hartwell 2 catheter, to cut the balloon first when you encounter the undeflatable balloon?
No, but that was the next plan if the ultra high pressure inflation did not work, because the patient is really having chest pains and very unstable at that point. So the fastest thing to do is to try to ultra inflate the balloon and hopefully it will deflate. But luckily for us, it did.
Do you think that moving forward, if this were to ever happen again, if you had difficulty removing the balloon the first time, you would then exchange it for a new balloon? Do you think that's ultimately the problem here?
Yeah, but I think this is a rare case, but we asked the manufacturer to take a review, and then to our surprise, there were other instances where the same batch of the balloons are defective. So
well, that's great.
That might be the problem. Yeah.
Very good. We can continue to discuss, but we have to move on to the next presentation. Thank you very much, Dr. Yumo.
All right. Thank you for this opportunity. Thank you.
Our pleasure. Next up is a colleague from one time zone over, so 1 hour earlier, Joseph Reed out of Case Western, who will be discussing some MRI findings for left atrial appendage.
Hello, everyone. My name is Joseph Reed. I'm a PGY1 in internal medicine at University Hospitals in Cleveland. Today, I'll be talking about left atrial appendage closure using cardiac MRI for device sizing and pre-planning. Here are disclosures and learning objectives. So today, we'll be talking about the procedural options for left atrial appendage closure device sizing and planning, and discuss relative contraindications in using certain imaging modalities for this process, and to demonstrate how cardiac MR can effectively be used in patients who have relative contraindications to transesophageal echo and CTA for left atrial appendage closure. And here are abbreviations throughout the presentation. And to introduce the topic, most centers use transesophageal echo for left atrial appendage closure pre-planning and sizing under current recommendations. However, studies have shown that effective left atrial appendage closure planning can also be performed with CTA. At university hospitals, we are a CTA first institution. However, patients presenting for left atrial appendage closure, they may have comorbidities that preclude them from CTA or TE for the pre-procedural planning process, and those include chronic kidney disease or esophageal disease. And here we present a case in which the pre-planning process was performed using cardiac MRI in a patient who had contraindications to CTA and who was unable to tolerate transesophageal echo. And here is our case description. It's an 82-year-old female, history of paroxysmal AFib on apixaban, stroke, heart failure, advanced CKD. She required left atrial appendage closure due to recent GI bleed. Her CHA2DS2-VASc score was 6 and HAS-BLED was 4. CTA was deferred due to her GFR being less than 30, and she was unable to tolerate TEE due to her stroke-related dysphagia. So thus we went and proceeded with cardiac MR for the device sizing and pre-planning process. So here are our findings using cardiac MR. The LV was moderately dilated with LV dysfunction. Her RV was mildly dilated. Her LA was severely dilated. And on cine imaging, early long T1 and late gadolinium demonstrated no presence of LA thrombus. Our measurements of the LA ostium were an area of 717 millimeters squared, diameter 32, minimum diameter 28, depth of 34. And using these ostial measurements, we selected a 35 millimeter Watchman device, and we extrapolated data from CTA sizing algorithm that University Hospitals has developed. Here is perfusion imaging demonstrating no left atrial appendage thrombus. And the sensitivity for ruling out thrombus here is 94% with a negative predictive value of close to 99% using cardiac MR. And here is our cardiac MR imaging of the left atrial appendage ostium. Here's gradient echo cine imaging. And panel A here on FOSS, LA size were orthogonal. And here's the 2-chamber view. And here in panel C is the 4-chamber view. And our measurements are listed here again in the right corner. For the procedural step, we accessed the right common femoral vein using the Seldinger technique. Heparin was administered. Left atrium was accessed with an ICE probe. Baylis needle was used for transeptal puncture. We used the double curve access sheath for device deployment, and left atrial appendage angiography was performed using a 6 French angled pigtail, and left atrial appendage closure, device sizing was confirmed via angiography and ICE imaging. And after satisfying the position, anchor, size, and seal criteria, 35 millimeter Watchman Flex device was successfully deployed with 28% compression, and that was under a single deployment. And we successfully deployed this device, and the patient was uneventfully discharged home on the same day without any periprocedural complications. Here is left atrial appendage angiography for access, demonstrated here. And here is intracardiac echocardiography confirming left atrial appendage closure device sizing. This is ICE imaging prior to device release, and these images show device with expected compression without colored Doppler flow around the device. So for follow-up, obviously the patient was discharged on the same day uneventfully. For follow-up, she remained stable without any new adverse events at 3 months. And our anticoagulation strategy was aspirin and Plavix for 6 months and aspirin for life. And the patient declined 45 days surveillance imaging. In summary, CTA or TE are accepted imaging modalities for the pre-planning process for left atrial appendage closure. However, not all patients can tolerate esophageal intubation. TEE has complications. It's been associated with esophageal perforation, intramural hematoma, GI bleed, etc. CTA is also contraindicated in patients with renal dysfunction. While studies have demonstrated utility in CMR for planning structural heart procedures like TAVR and MitraClip, no study to date has evaluated a cardiac MR for LAC planning. Our case highlights the possibility of using CMR for select patients, those with esophageal or for stroke-related dysphagia, esophageal abnormalities, and also with renal dysfunction. In conclusion, we safely used cardiac MR in this patient who had a contraindication to TEE and CTA, and we provided detailed anatomy of the LA using cardiac MR and accurately predicted the appropriately sized device in our patient, and no adverse complications were detected 3-month follow-up. Thank you.
This paper is open for discussion. Any discussants wish to ask any questions? Please, Dr. Buseyev.
Thank you very much. Thank you. Thank you for your great presentation and great idea of using MRI for planning of the procedure. And MRI is less invasive in case of X-ray and the contrast. And I have 2 questions. First question is, did you use contrast during cardiac MRI? And second question is, will the cardiac MRI be the same indications as CT and TE at the future? Thank you.
Thank you for your question. Yes, we use gadolinium contrast for this patient here, and CMR definitely has limitations in prior papers with regard to device sizing and planning. It does, though, serve as an alternative in this case to a patient who was unable to tolerate TEE from her stroke, who was able to tolerate CTA from her renal dysfunction.
May I make a comment? Since you are doing ICE on the patient, what's the value of the CMR? I mean, in what way the ICE, is it for the puncture or is the sizing?
It was to confirm the left atrial appendage access and make sure that the appendage was appropriately sized and to appropriately determine the compression.
If there's no further comment, I would like to ask the third presenter, Dr. Wei-Jun Lo from Taiwan, to present his case. Dr. Lo.
Okay, hello everyone. I'm Dr. Wei-Jun Lo, and I'm come from Taichung, Taiwan. And I'm going to present a case of alternative treatment strategy for grave failure in STEMI. Okay, this is a 61-year-old male, and he has a past history of triple basal coronary artery disease. And he received CABG, which was grade 7 ventral LAD and grade 7 ventral ON and PDA in 2005. He also had type 2 DM and hyperlipidemia. He suffered from acute onset chest tightness, jaw pain, and cold sweating in the early morning, and he came to our hospital for help. Initial ECG showed ST segment elevation over inferior lead with reciprocal change over AVL and lead 1. He received primary PCI under diagnosis of inferior wall STEMI. The coronary angiography shows severe stenosis of proximal RCA and total occlusion of distal RCA, middle RCA. And then grade 7 ventral LAD was patent. Another grade 7 ventral OM was patent. However, when grade 2 PDA was total occlusion. Initially, we consider total occlusion of middle RCA as the cusp-free region, and we decided to perform PCI for it. And SL guiding catheter was engaged to RCA, and then we support an APT microcatheter. Filter FC and filter XDA could not cross the RCA CTO region. Then we decided to shift approach to vein graft. And SL guiding catheter was again engaged to vein graft, and filter FC could advance to distal RCA successfully. And then with this manual thrombol aspiration with eliminator. After thrombol aspiration, the angiography showed huge thrombus over distal vein graft and severe stenosis over vein graft to PDA junction. We did distal dilatation with ballooning and intracoronary aquastate bolus dose infusion with eliminator. And the flow from vein graft to PDA becomes to TME2 flow. However, huge thrombus over distal vein graft and severe stenosis over vein graft to PDA persisted. So we decided to do RCA intervention in case of poor flow of thrombotic vein graft. Then another SL guiding catheter was engaged to RCA, and then retrograde Gaia second guide wire was advanced to middle and distal RCA. With distal wire guiding, we use kissing wire technique, and antegrade Gaia second was advanced to distal RCA successfully. And however, the microcatheter and the 1 millimeter balloon catheter could not cross the RCA CTO lesion. And with support of guideliner, the 1 millimeter balloon catheter could cross the CTO lesion, and middle RCA was dilated with this balloon sequentially. And during retired balloon catheter, the antegrade Gaia third was flow out due to severe impingement of guide wire and balloon catheter. Then we try to approach back with antegrade approach back with STR guide wire but fail. So we try to retrograde approach back with filter FC. And then filter FC could advance to antegrade guiding catheter successfully. Then we use retrograde reservoir technique. Then antegrade microcatheter could advance to distal RCA through the retrograde filter FC successfully. And then we replaced the microcatheter with seal blue guide wire. And seal blue guide wire could advance to gray cephalus vein. And then proximal to distal RCA was dilated with 1.5 and 2.0 millimeter balloon catheter. Then we use IVUS to check the vessel size and confirm within the true lumen. Then proximal to distal RCA was dilated with non-compliant balloon catheter. The angiography of RCA show restore some blood flow. Then with guideliner supporting, 2.5 millimeter drug-eluting stent was deployed at middle to distal RCA, and 2.75 millimeter DS was deployed at proximal to middle RCA. And finally, the 3 millimeter DS was deployed at OCN to proximal RCA. After the stent deployment, RCA was post-dilated with larger non-compliant balloon catheter. And then final angiography of RCA showed TME3 flow, even to the gray cephalus vein. And here I present a case of graft failure which caused ST elevation myocardial infarction. And it's essential to understand the characteristic of vein graft. And my conclusion is that acute occlusion of gray cephalus vein is commonly associated with extensive atherosclerotic and thrombotic burden, and which increase the risk of distal embolization and non-referral, and thus death and myocardial infarction. And preferentially intervention of naive coronary arterial circulation should be considered as an alternative route to make reperfusion of myocardium, and if possible, will result in higher acute success and late patency rates. And there are many factors associated with PCI target vessel selection, including the severity of cephalus vein graft disease and the severity of naive coronary artery disease. Thank you for your attention.
Thank you for the presentation. I would like to invite the panelists for their comments.
Hey, hello. I have a question.
Yes,
yeah,
hey,
very good. Yeah, very good case. But after RCA recanalization, the PDA flow is still not very good. distal PDA flow. So
Yeah.
would you consider to just use a glycoprotein 2B3A inhibitor for a few days and come back and get the patient back and to look at the thrombus, if the thrombus disappear or not after a few days?
After the procedure, we use this medicine actually. And after 3 months, we also check the coronary angiography for this patient. And his PDA flow become much better than this time. Yeah.
So Dr. Lo, hi, I'm Dr. Chow from Hong Kong.
Hey, hello.
So how long was the procedure, and was the patient hemodynamic stable during the procedure?
This PCI we spent about 6 hours, and the total this patient hemodynamic is very stable. So we try to do the CTO procedure because his hemodynamic is stable. So there is no IBP or no ECMO supporting. Yeah.
Okay, good. Because I asked this question because I just wonder in the case of STEMI, so is this suitable to have a so lengthy procedure for the patient with STEMI? So I agree with Dr. Choi that for me, I would give 2B3A inhibitor. But I have a question. Does the ST elevation come down after you give the 2B3A inhibitor? You said you give the thrombolytic to the patient, right?
Yeah.
So the ST elevation come down after you give the thrombolytic?
Yes.
Oh, okay.
Yeah, that was a very complex case. I think it was some excellent techniques and use of the rendezvous and retrograde and antegrade. Thank you for your presentation.
Oh, thank you.
Next is from Thailand will be our colleague, Dr. Mantravadi, who will be discussing the retrieval of a broken rotowire using some combined techniques. Dr. Mantravadi.
Good morning, everyone. My name is Dr. Sakonwat Mantrawet from the Police General Hospital, Bangkok, Thailand. It's my honor to present my case entitled Retrieval of a Broken Rotor Wire on ALG Cuffs using Combined Twisting Wire Technique, Microsnare, and Patient Cuff. I have nothing to disclose. My case is a 75-year-old man with diabetes, hypertension, chronic kidney disease on regular hemodialysis. He had intradialytic hypertension. From echocardiogram review, RVF of 50% and hypokinesis of anterior and inferior wall. So we proceed with angiography, and it revealed a 3-vessel disease with heavily calcified proximal to mid-LAD. For the RCA, this is a CTO of osseous RCA with a long, heavily calcified and tortuous course. The patient refused to undergo CIBG, and PCI of RCA is failed, and it deemed not possible for PCI. So we scheduled the patient for PCI LAD with vertebration for symptoms relief. For the PCI LAD, I used femoral access, and IWAS could not pass mid-LAD. So we proceed with rotational atherectomy using rotor wire floppy and 1.5 millimeter burr for 5 rounds, and they are successfully performed. However, there was during the rotor burr removal, there was an unintentional wire prolapse while activating dynaglide mode, and it caused the rotor wire to fracture and dislodge into the distal LAD, as you can see on the left-hand side. Now it's fractured. Okay, so when we check, the rotor wire fragment is now at the distal LAD. So what are you going to do in this situation? First, to use a microsnare kit, but it may be difficult to pass to the very distal part, or use the thrombectomy devices, but rotor wire had larger tip than the shaft, so it may be difficult to aspirate. Switching wire technique may be the most suitable for this space, narrow space, such as a distal LAD. fix with an additional stent is maybe unable because it's small at the distal side, or we may just leave it like that and do a conservative approach. At that time, I first stent the proximal and mid LAD first and deal with the rotor wire fragment later. First, I use the twisting wire technique by inserting two workhorse guide wires positioned in parallel and rotate simultaneously with a torquer. And we can bring the wire back into the left main carina, but not into the guiding catheter. Again, I tried to switch to micro snare, but it failed to capture. And also the second attempt of switching wire technique could not grasp the wire and bring it to the guiding catheter. Unfortunately, when we checked again, the rotor wire fragments embolized onto the coronary cuffs. In this situation, it may be very difficult to retrieve because it's a free space. Our option may be to use a bigger catheter and aspirate the wire, or use a different snare such as the gooseneck or multi-loop, or lastly, just leave it like that and do the conservative approach. So I failed to insert the AL1 catheter to retrieve and aspirate the wire, but luckily, as our last option, I instruct the patient to forcefully cough, and this luckily it caused the broken rotor wire to bounce back into the left main. Lastly, I used the micro snare and successfully captured the broken rotor wire back into the guiding catheter and get it out of the patient like this. As you can see, the tip of the rotor wire is bigger than the shaft, so it may be difficult to aspirate. This is the final angiogram. This was no serious complication. My take-home message is that do not prolapse the wire while activating dynaglide mode ever. And second is to retrieve the wire fragment. Twisting wire technique is more suitable for narrow spaces such as distal LAD, but in the large spaces such as left main carina, micro snare is more appropriate. And instructing the patient to cough may bring the wire back from the aortic cuff into the coronary artery. However, the risk of wire embolization to peripheral artery is unpredictable. Thank you.
That was a great presentation. This paper is open for discussion. Any questions from the panelists? If I could ask you one just a simple question, maybe I just can't see it. My eyes are getting worse in an old age. You stented the LAD prior to attempting your retrieval of the wire, if I understood you correctly. How did you know that the proximal end of the wire was not going to be entrapped by your stent?
I already removed the rotor wire and exchanged it into a workhorse guide wire before stenting.
I'm talking about the embolized piece of wire. How do you know that proximal end was not going to be entrapped by your proximal stent? Could you see the proximal?
Well, the wire is embolized into the very distal part of the LAD, so I think it's safe to stent the proximal and mid LAD in this situation.
Okay. Any other questions?
Yes, I'm Dr. Tiernan from Thailand. Congratulations for your difficult case, but I have the question about your RCA lesion. How do you plan to do before you do the PCI of LAD lesion? Have you ever done any non-invasive for myocardial viability of RCA territory? Have you done before?
As I mentioned before, we tried attempting to do the CTO PCI of RCA, both antegrade and retrogradely, but it failed. So we just fixed the LAD for symptoms relief and leave the CTO RCA like that.
And how you will you do with your RCA lesion? Or do you think this is a infarct area of the RCA that you didn't plan
it's
to do
still
more?
viable, but at the end of the procedure, we can see that the collateral to the RCA is still preserved. So if the patient did not have any more symptoms, I think we just leave it like that and just optimize the anti-anginal medication.
So
All right. Well,
the normal site of the rotor wire fracture is at the radial opaque and radiolucent junction site. That's the most common site of fracture. So that your case is not at that site, right? So what is the cause of the disruption of the wire?
The wire, there was an unintentional loop of the wires. So when we still activating the 9-degree mode, it can twist the wire at the loop and fracture it like that.
Dr. Chen.
Yeah. Should we move on to the next presentation? The next presentation is by Dr. Aris from National Institute, Heart Institute in Malaysia. Dr. Aris, thank you.
Hello, hi. I'm going to present a case, A Night to Remember. It's a case of inferior MI where I encountered during one of my on-call recently. So I'll begin my presentation. I have no conflict of interest. So my patient is a 66 years old gentleman with underlying diabetic hypertension. He presented to another hospital, non-PCI capable hospital with history of chest pain for 6 hours. The ECG showed ST elevation over the infralateral leads. So the patient actually presented with acute infralateral MI, key lead 4, and also APO. So when the case was referred to me, I discussed with my consultant and was immediately asked for intubation, and then initially was supported with single inotropic support and was asked to transfer to our center for a primary PCI. So this is just a glance of the ECG. So this is the diagnostic angiogram showing a very tight stenosis over the mid-LAD, left anterior descending artery. So there is no flow in the from the proximal left circumflex artery, and this is the right-sided shot. So there is a total occlusion from the proximal RCA. So yeah, my patient presented with acute inferior MI in cardiogenic shock and also APO. From the summary of the coronary angiogram that I've showed, there is a very tight mid-LAD with diffuse disease distally. And also there is ambiguous culprit artery whereby the left circumflex occluded proximally with re-tapering stump. We are not sure whether it is acute or chronic total occlusion, absence of retrograde flow. So the right side, there is a moderate ostial to proximal, then totally occluded. But we can see from the angiogram, there's a contrasting the distal pad before the injection, very faint anti-grade flow. So at the time, we have a dilemma. It's a 3-vessel disease with occluded left circumflex artery and right coronary artery. Patient in cardiogenic shock. We have ambiguous culprit artery. We are not sure whether this time the MI is caused by the left circumflex artery or whether from the right coronary artery. Both are possible to be dominant. This is a very difficult choice, but we go for the right coronary artery first, as there is a faint anti-grade flow still present. With hopeful, we have a higher chance of crossing. So first and foremost, because patient is also in cardiogenic shock, we inserted intra-aortic balloon pump via the left femoral artery access. And then while we are stabilizing the patient, actually needing a triple inotropic support. So we are able to cross the right coronary artery quite smoothly with only a soft wire run through floppy. We start to pre-dilate with a 2015 balloon. So this is just a series of pre-dilatation from the distal to proximal of the RCA using a 2515 balloon. So this is the immediate result post-ballooning. I will say that there is a DME3 flow achieved, but we are not really happy with the result. We further prepare dilation with a scoring balloon 3015, and this is the result after the scoring balloon. So we are happy, and then we stand the RCA from the distal to the proximal with a drug-eluting stent 3030 and also 3526. This is the final result of the RCA. So because the patient is still in cardiogenic shock with the ambiguous culprit artery, so we thought we just attempted a PCI to the left circumflex. We try with the soft wire run through floppy, entry of the wire into the lesion. As you can see, we try to wire, and then we are able to wire not to the true circumflex artery, but to the branch of the OM. So it's a very tight bifurcation angle into the true left circumflex artery with 90° of angle. We tried to wire many times into the true left circumflex artery while we are also pre-dilatation deletion. But however, we are unable to wire the true circ. We took about, I think, about 20 minutes trying to wire to the true circ. Unfortunately, we couldn't. So this of the into the OM. We tried using a second wire, but in the end, we are unable to wire the true circumflex artery. So after 20 minutes, we thought we have to stop, and we thought we need to open the LED because the mid LED is a very, very tight lesion. So it was a rather smooth PCI to the left anterior descending artery. We use a long stand 3030, and this is the final result of the LED after the PCI. After that, we actually come back to the relook the left circumflex artery. We see there is a bit of, again, compromised flow. We are able to achieve probably about TIMI 2 flow just now, but this one the flow is compromised again. We repeated the pre-dilatation, and we're still trying to wire to the true circ. However, it's failed again. We decided to stop at this moment because the procedure is already about 1 hour 45 minutes. And we decided to accept the results. So this is the final result of the circ. This is the LED. Yeah, so after that we inserted a Swan-Ganz catheter post-procedure, and the patient is able to extubate it after the 2 days, and we are able to off all the 3 inotropic support after the 4 days, and patient was discharged after a week with a plan to restudy the left circumflex artery. So I've illustrated a multi-cardiogenic shock is an everlasting dilemma for a primary PCI operator. In this case, there is ambiguous culprit artery compounds the problem. So in the primary PCI, ischemic time that allows the operator to intervene is very limited. In this case, we choose more crossable lesion as our first target, and then allow some recovery, which cascade more safer PCI to the non-culprit artery. However, similar cases like this will never be replicated in the randomized control trial. So as a conclusion, this case demonstrated the success of opening almost all major vessels in cardiogenic shock. It is a very tricky situation, balancing need of revascularization versus a procedure time in face of cardiogenic shock. Meticulous post-procedure intensive care is paramount to augment survival in cardiogenic shock patients. With all, end my presentation.
Thank you, Dr. Aris. This presentation is open for comments from our panelists. Just want to ask Dr. Aris, have you tried crusade catheter to cross the circumflex, which is a double lumen?
We did not, because the patient is kind in cardiogenic shock. We thought we don't want to further taking longer times. We actually wanted to shorten the procedure, but we plan to reattempt the PCI to the circumflex artery later.
The one thing I would offer is that, I like the idea of the double lumen and the side approach, but the one thing that I think this procedure demonstrates is stopping, because what you could have done was make things a lot worse in that AV groove circ, and as long as you maintain some flow, there is an opportunity to come back and fight another day, as long as they did get better and out of cardiogenic shock. So I thought that was probably your #1 step that was very, very useful. Because if you keep on trying, you may make things a lot worse.
So this is cardiogenic shock, complicated acute myocardial infarction, I think. And you are doing the multivessel PCI, and the patient has a 3 inotropic. So I think due to the PCI, the patient may need more support. So therefore, I would suggest to use Impella or ECMO for this case, because probably during the procedure, patient may have more ischemia. probably the hemodynamic can be getting worse during the procedure. I think more support space is safer.
Yep, agree, totally agree.
Dr. Sao, how often do you use Impella in your center? I mean, we are very restricted here because it's very expensive.
We don't have an Impella in Taiwan yet, but we are using quite often the ECMO in this kind of patients. And we insert the ECMO before the procedure, not during the procedure.
In all the data.
How long can you, maintain the ECMO? I mean, because the ECMO basically, after a while, the LV will start to dilate. You know what I mean? So
yeah.
So this is also quite limited to what you can.
Most of our cases, we remove the ECMO right after the procedure, and some of the patients we keep the ECMO just for 1 or 2 days. Most of the patients we just remove after the procedure. Yeah.
One of the challenges from Abiomed is that there are a lot of people doing it, at least in this country, with facilitated PCI so that they can do it with Impella support. The challenge is that the denominator of the entire group may or may not be necessarily the right group to test it out. So it really does become a very murky or muddy water. Patients like this are probably very clearly benefited with extra support beyond a balloon pump, which we've used for 20 or 30 years. But the challenge is that there's not every patient is similar to this in their facilitated PCI registries. And so it does become a bit of a challenge to tease away those who most benefit. But I think this is a pretty good discussion in regards to that one mode for help when it comes to support, because it does unload the LV to a much greater degree than ECMO will ever do it. But I agree, it's a very challenging case. Any other further discussion? We have one last presentation. It is my honor to present from India Dr. Tama Kuwala, who will be talking about percutaneous transcatheter closure of a large spontaneously ruptured sinus aneurysm in a young female.
Yeah, I am Dr. Kunal Tamapuwala, cardiologist practicing at KD Hospital, India. There were no conflict of interest. She was a 32-year-old female patient, non-diabetic, non-hypertensive, with no cardiogenic risk factors, presented to emergency department with history of projectile vomiting, chest heaviness, palpitation, perspiration, and worsening of shortness of breath. And of course, there was a decreased urine output past 24 hours. She was anuric. On primary survey on examination, the patient had dyspnea at rest, NOIHA class floor with respiratory rate of 30 per minute. She was vitally stable, like oxygen, 98% on room air, pulse was 100 beats per minute, BP was 120/80, but over few hours of time, she went into cardiogenic shock. Electrocardiography showed sinus regular narrow complex tachycardia. On auscultation, there was a grade 3 continuous Merwert best heard in the left, second, and third intercostal space on parasternal line. Echo showed RSOV communicating between the NCC to RA, present just about the tricuspid wall, measuring 10 to 11 mm. So according to the classification of RSOV, it was class 3A. IVC was dilated and non-collapsing. Severe pH was there, and she had a good LV systolic function. So a TE was performed, which revealed RSOV arising from a non-coronary cusp, coronary sinus, and communicating with the right atrium. So procedural steps were the aortic rim showing the large sac with the rupture. So all procedures were performed under a GA under TE guidance. The femoral vein and artery were assessed by 9 French and 5 French sheath respectively. Aortic ruled angio was performed by 5 French pigtail catheter. and the LAO cranial tilt projection was taken and performed for RSOV to show the RSOV draining into RA. RSOV was measured at the aortic end by angiography and a TEE guidance. The size of ADO device selected was such that the aortic segment was 2.2 to 4 mm larger than its diameter. Then the defect was crossed from the aortic side using a 5 French multi-purpose catheter over a 0.035 straight tip guide wire thermo with catheter across the RSOV exchange length. Wire was taken, then 0.035 into 260 was passed into RA to IVC from the aortic end, as you can see in the video. Then the wire was snared. The wire was parked in the SVC, and it was snared through the gooseneck snare from the venous side, right femoral vein sheath and a venous side. So AV loop was made. And 9 French long Emplazar device sheath over the exchange length wire across the defect. And finally, we got the ADO. The ADO with its attachment delivery cable was deployed at the aortic end first, and it was pulled back gently. And finally, the right atrial end was deployed. There was a root angiogram was taken to see if there any leak or significant AR is there, or there any engorgement of right coronary ostia. This was a TE procedure pre-procedure where you can see RSOV rupturing into RA. This was post-procedure TE where you can clearly see a device from non-coronary cuts to RA, and there is no peri-device leak. So we had a patient underwent a transcatheter device closure, and defect of 11 mm was closed successfully with 16-14 mm Emplazar PDA occluder. It was minimal residual flow peri device on TE and aortic root angiogram, but on 3-month follow-up, when we did TE again to see whether the flow is still there, but there was no flow. So discussion in PDA occluder are cost effective, and also we have advantage over surgery, open heart surgery. Previously, two series of Dr. Sinha has series of 8 patients with CDO at success rate of 87.5%. In this series, largest device was 10 mm and largest size of device was 14-12 mm, and defects of 14 mm or more were referred to surgical correction. Where Guan et al. The series was safe percutaneous device closure of RSOV with defects larger than 10 mm were closed using 14-18 mm PDA device. In our study, patient had defect size of 11 mm, where we successfully interpreted with 16/14 mm Emplazar PDA occluder. The potential problem with the bigger device is worsening of pre-existing or development of new AR or a coronary ostial pinching, but we encountered none. We checked all results with the TE as well as concluding aortic root angiogram. Patient was stable after 3 months of follow-up. We had procedure success of 100%, and to the best of our knowledge, have used one of the biggest 16/14 mm Emplazar PDA occluder till date. So take home message will be, RSOV aneurysm is a rare cardiac deformity that carries a severe prognosis. TTE is sufficient to actually diagnose the condition. Device is used to occlude the defect in an economical modality of treatment with good short-term and intermediate outcomes. In carefully selected patients, this provides an alternative for larger defects, thereby avoiding the inherent morbidity for sternotomy and cardiopulmonary bypass. Thank you very much.
Thank you very much. That was a great presentation. This paper is open for any discussions. Any questions from our panelists? If I can start it off, you said this is a very young lady with this fairly rare deformity. Given that she ruptured into her RA and she was getting fairly sick, I presume that had you tried to close this and had AI as your complication, were you willing to then send her for root repair? Could this be used as an alternative by way of a temporizing measure to get them to surgery as opposed to a definitive therapy?
Sir, this is a very emergency procedure. If you see any rupture in the aorta, it should be immediately sent for surgery. Immediately. I mean, immediately means it has a severe prognosis and person can die immediately within hours. So if any complication such like that, because we have a fine nowadays a device closure is available, so we can prevent her from with very young age. She was unmarried, and we can prevent her for a sternotomy or bypass, the open heart surgery.
Any thought from the panelists about the occlusion device in an aneurysm segment? Is it
Were you worried about the possibility of interfering with the ostium of the RCA? I mean, do you make sure that the disc in the aortic aspect is not encroaching the ostium of the RCA?
Yeah, we had sorry to interrupt. We had aortic angiogram post-procedure, immediately post-procedure, and there was normal coronaries, no encroaching of right coronary ostia was there.
Well, it's a bit late if you do it after the delivering the device, you know. I mean,
we had when the aortic end was deployed, at that time we had an angiogram.
Okay.
Before releasing the right atrium end, or before deploying the right atrial end, and with the pigtail also, with yes, some pressure over the aortic disc side. We have classically enumerated that there was no encroaching of right coronary ostia.
All right. Well, I think our time has come to a conclusion. On behalf of my co-moderator, Professor Chan out of Singapore, and myself, Dr. Garcia out of Boston, it has been my pleasure. I want to thank all the panelists and all the presenters for presenting some really challenging and some wonderful cases. And I hope that TCTAP will continue to grow. And I look forward to next year where we can actually do this in person. I miss Seoul and I'd like to get back to it. So thank you and have a good day or a good evening wherever you are in the world.
Thank you.
Thank you very much. Thank you.
Bye-bye.
Thank you for giving me the
Thank you.